Hello, ladies and gentlemen. Thank you for attending my lecture today on autosomal dominant polycystic kidney disease, specifically relating to stone formation risk and reduction strategies. My name is Michael Leotis. I am the Division Chief of Nephrology at Upstate Medical University in Syracuse, New York. And I'd like to thank the PKD Foundation for their wonderful invitation and for allowing me to present to all of you today. So we have a lot of things to go through with regards to kidney stone formation with patients that have polycystic kidney disease. And what are the mechanisms that make that a little bit more unique than in the general population that tend to have polycystic kidney disease? So we're going to go through what makes this a little bit more unique when we're thinking about kidney stones and ADPKD. What are some of the strategies we can use to try to think about stone reduction? And what are some of the things that we should be thinking about as far as changes and other things that we can do in conjunction with our treatment team to help to minimize future risk of stone formation? So let's go on and take a look at other things about kidney stones. So kidney stones are also referred to as nephrolithiasis in the medical literature. So you may see them as kidney stones, or you may see the term nephrolithiasis, and that is actually one and the same. It's a very common medical problem in the general medical population. So nearly 10% of women and 20% of men will have a stone in their lifetime. And, however, in ADPKD, that risk is higher. So in patients with ADPKD, they tend to be at 20 to even 35% of risk of having a kidney stone. And nearly 2/3 of those patients that have a kidney stone in ADPKD will have some symptoms. And we'll go over what are some of the signs and symptoms of kidney stones and active stone disease that a person may have. Sometimes people may have kidney stones and they're completely asymptomatic. They don't feel any differently. They don't function any differently. But however, on imaging, they may have stones that are present. So let's think about those a little bit more. So what exactly is a stone and how is it really going to get formed? So let's look at that a little closely. So in general, 85 to 95% of all kidney stones will typically contain calcium. So calcium is found in a lot of our foods, dairy, in our diets. And actually, calcium oxalate tends to be the predominant form of stone for the vast majority of patients in the United States. Approximately 75% of patients will have a calcium oxalate stone if they happen to have a stone. Calcium phosphate tends to be the next most common, and so that's about 15%. However, in ADPKD, it's a little different, where uric acid stones tend to be a higher percentage. And the risk of stone recurrence, which means if you've passed a kidney stone or you've had an intervention on a kidney stone, well, that may very well be that you will go ahead and have a future stone or be at risk for a future stone. And up to 50% of patients will have another stone in approximately 9 years. So why do kidney stones matter? Well, we sort of know that answer, but let's go through it a little bit more. Well, they cause pain. Patients that have had an active stone that they've been trying to pass is an excruciating amount of pain that they can go through. Sometimes it's lateralized to the side to the active stone, where if it's on the right side or on the left side, you can have extreme flank pain. There could be bleeding associated with it. As the stone is passing on through, you can have some bleeding. There's an infection risk, especially if the stone kind of stops up and gets stuck in a certain spot as it's trying to move. You can actually have accelerated loss of kidney function. As you think about it, if you've got infection and bleeding and pain on the sides, you're not eating and drinking well, you can certainly think about how these stones themselves can cause perhaps accelerated loss of your overall function in your kidneys. Additional things to think about, well, if you're having all those things, well, you're going to seek medical attention. You're going to go to the emergency room. You will go to the urgent care center. You will go to your urologist's office. You will go to your nephrologist's office. You will seek care because of that pain and try to get some pain relief. And as you think about all those things, well, you're not going to be going to work. There's going to be lost work that's associated with this. In fact, some studies have indicated that you can have even billions of dollars in lost work for patients, seeking medical attention, not being able to go to work, having to be hospitalized because of a kidney stone. Now, that's also in addition to, well, you may require some intervention in order to have a kidney stone to get that, passed. And sometimes those interventions can be much more than just IV fluids. And, they may require a urologist to go and do shockwave lithotripsy, where you try to fragment the stone, or you can have percutaneous nephrolithotomy performed. So let's take a look and think about, well, what are those that last, specifically that percutaneous nephrolithotomy? So let's look at an example here on a CT scan. And this is a CT scan. It's a non-contrast CT scan of a patient with autosomal dominant polycystic kidney disease. Now, when we look at this here, what we'll see here is on the left side, and this is the right side. So just imagine somebody's laying down on the table and their feet are coming right on out at you. Now, and they're looking up. So this is actually the left kidney. This is the right kidney. And you can see here, right in this spot here, where you see just something that's very bright white. Well, that's a kidney stone. And so you can see that kidney stone that is there in this picture and of this CT scan. And then in the next one here, you see where you've had an intervention that's been performed to have that stone extracted. And so you no longer see that very bright white aspect to it. And so you can see how this is an invasive procedure. And, it has a certain amount of risk that's associated with it. However, removing that stone certainly outweighs the other risk of going ahead with such a procedure. Now, and then we could see it here in the subsequent picture where we don't see anything whatsoever. But let's look at kidney stones. Let's look at why is it that patients with ADPKD, what is it about them that tends to make the risk of forming a stone greater? Well, let's look at that a little bit more in detail. All right. So we think that these kidney cysts, and I'll show you another picture of a kidney with cysts on it. So we think that these cysts, as they start to form, interfere with the way that urine kind of flows in a natural way. And so you can kind of see it as more like rapids. It kind of goes a little bit on one spot, pause, goes to another spot, and it kind of meanders on through. And we think that patients with larger cysts and those with an increased number of cysts are more likely to form stones. And we think, again, this is due to this obstructive or partial obstructive effect of these cysts that kind of prevents urine from flowing well, and therefore also prevent a kidney stone from then flowing down past the ureter so that you can urinate it out. And it causes kind of urinary stasis, which means, again, urine kind of tends to kind of not flow as well down out of the kidney. So when we look at this, we want to see a CT scan that may show us this a little bit more in detail. Imagine all these cysts, and as you're trying to normally create urine, it's kind of interfered. The passage going on out is kind of blocked in certain areas. It moves in certain areas. And so it's not, again, a free-flowing aspect that we theorize may interfere with your ability to pass a stone or, again, to be able to create a good urine flow on out. so that stones don't really linger and potentially grow. So let's think about this now. Part of the way to treat a stone is to really understand, well, what kind of stone do you form? Now, earlier in my presentation, you'll remember that I went through basically the three most common kinds of stones. Well, there's multiple kinds of stones that are potentially out there that a person can form. And I just mentioned really the top three. But as we think about it, if you have that stone, if you've passed the stone and you can collect that stone, well, now we know exactly, well, what is it that you may tend to form? And if we understand what you may tend to form, now we can go ahead and perhaps really target our treatment and our therapy to that kind of stone formation. Depending on the kind of stone you form, your treatment will be just a little bit different. And we'll go through all that in just a little bit. So that urine biochemical composition can also contribute to an increased risk. Well, as I think about that and try to explain it a little bit more simply, basically that urine that you're making is unique to you, and certain factors that are either too high or too low in may increase your risk of forming a specific kind of stone. So let's look at that a little bit more. And what could those things be? So to really understand that urine biochemical composition, fancy term of being able to think about, well, if I collect your urine in a 24-hour time frame and I measure it, I'll know many things about you and about your potential risk of forming a specific kind of stone. I'll know if you're being able to keep up on your hydration properly, because I'll look and see how much urine you would be making in a 24-hour time frame. And then I would know other characteristics about what your urine is like to see about different kinds of risk factors. And I've outlined here really the top ones. There are many more that we get when we look at a 24-hour urine collection. However, here are some of the top ones. The urine output, of course. If the citrate level is low, and we'll go through all of these a little bit more in detail. We'll look at if you're excreting very high levels of calcium in your urine. We'll look at if you excrete very high levels of oxalate in your urine. And then we'll look also at the urine pH, which tells me a little bit more about, again, the type of stone that you may have a tendency to form. Now, these factors will help me to understand a little bit more about the kind of stone that a person can form if I don't have the actual physical stone present. If I have the actual physical stone present, these will be complementary. If I don't have that stone or a sample of that stone necessarily present because it's too small, we haven't gotten it, it hasn't passed, these factors from the urine biochemical composition will help me to understand what is it exactly that you're at more of an increased risk to form. So let's look at what do I mean by a low urine output. Well, a low urine output, if you're at risk for forming a stone, is typically really, and you want to have it, you want to make more than 2 to 2.5 liters of urine a day if you form kidney stones. If you make less than 2 or 2.5 liters of urine a day, you will be at risk for forming a stone. Thought is, you're making a very dilute urine, you're having less chances for this urinary stasis that I was kind of mentioning before, so you kind of have a rapid flow, perhaps less of an opportunity in order to really form kidney stones by making a lot of urine. We certainly want to aim at about 2 or 2.5 liters a day. If you made 2.5 liters on one day and yet only made 1.9 liters the following day, well, that day was not a successful day. It really is about making 2 to 2.5 liters of urine every day. And that's really going to be the goal. And that's a challenge for patients. And it's a challenge for patients as you think about, depending upon what they do for a living. if somebody's a nurse, if somebody's a police officer, somebody's in EMS, or in a job where it is an office-based job where you have to do certain things and you don't have the luxury of being able to get up and utilize the restroom on a more frequent basis because you are being told to drink more, it makes it a little bit of a challenge. And so those are the things where, looking and talking with your medical team and thinking of creative ways of working with the situation that you may be in is really important. So once again, in order to make 2 or 2.5 liters of urine a day, well, your goal will be, well, you have to drink it at least 2 to 2.5 liters a day. So you will have to think about really a conscious effort of how much fluid you're drinking so that you can go ahead and make that amount of urine each day. So you can measure out water bottles. You can have a pitcher of water in the refrigerator. You can think about different ways in which you can figure out, well, how much fluid are you taking on in an effort to make this quantity of urine. Now, don't forget that our foods, unless you're eating dried crackers and cereal, our foods will also have a moisture or fluid content in there. They'll have a water content. So think about, again, your fruits and vegetables and really kind of thinking about how to augment your diet with, again, juicy fruits and vegetables. And that way you can go ahead and add that as a complementary thing to the amount of water that you're drinking each day. Now that we're in summertime, you will also want to think about, your hydration levels, especially if you live in a very hot climate, especially in the Southwest or Southeast, and you want to make sure that you're keeping up on that hydration. It's going to be extremely important. Now, this low urine citrate, it may also be, you may see the term hypercitraturia. And so that is typically defined as a citrate excretion that's less than 320 milligrams per day. Now, what's interesting about this thing, citrate, is that it helps to combine with calcium and it makes it less likely to bind with oxalate. So basically, citrate helps to make sure that that calcium doesn't kind of go ahead with oxalate, come together, and tend to form more stones. Now, citrate can also help too with urinary pH, and I'll get into that in just a few minutes. Once again, we want to try and prevent stones from happening. If somebody has had a stone, we want to deal with that stone, but we also want to make sure that we're thinking about that individual in the future. So a lot of this information that I'm going through not only applies to ADPKD patients that tend to have kidney stones, but in the general population. So we want to think about all these things, all these factors, and really understanding it, utilizing it to our advantage, and putting you as a patient or your friends or family that may have kidney stones in a better position for success for less stones in the future. High protein diets, as we think about protein currently, protein is one of those things that is very much in vogue in today's day and age as a way of building muscle mass or losing weight. But we have to keep in mind that our bodies can only take so much protein and utilize it in their diets. And sometimes very high protein diets may interfere with our citrate levels. So you will want at some point in time to really be thinking about all these factors and having an open conversation with your physician team and your medical team about, well, what are other things that you may be doing inadvertently that you think is benefiting in one way, however, may contribute to these stones in a different way. Now, high urinary calcium levels, hypercalciuria. So urinary calcium levels greater than 250 milligrams in females and greater than 400 milligrams per day in males tends to fit this definition. Now, it's a little bit of a difference here between men and women, and you need to keep in mind a couple of other things. So this is kind of like a slope. So it's not an on and off switch. if you are female and you make 249 milligrams of calcium excretion in your urine a day, that doesn't necessarily mean that you don't have increased risk. The risk goes on and up, but we have a definition here as far as a cutoff to kind of really help us. But again, it's a spectrum and it's a slope. The higher that your urinary calcium excretion is, perhaps the more risk that you will be taking on in forming a kidney stone. Now, it's not always due to a high calcium containing diet. Even though your medical team will be thinking about and asking you about your medical diet, you'll be thinking to yourself too that sometimes your team will think about other different levels in your body that may actually predispose you to getting more calcium. So don't limit your calcium intake unless your doctor tells you to do so. We'll talk about that a little bit later, why that's important. But you don't want to necessarily think of calcium as your enemy. You want to think of calcium as you need a certain amount in your diet. You just want to make sure that it's not excessive, and that way it's causing you to excrete more calcium in your urine. Now, when I say we want to look at other things in here, you may get some blood work that will look at different levels of your body of different aspects. And specifically, if you look at PTH levels, and very high PTH levels can also cause excretion of calcium in urine that can be high and form stones. And so there may be other reasons that are different than having the diagnosis of ADPKD or just kidney stones in general that are causing you to form these stones that could be potentially corrected from a surgical perspective. So these high urinary oxalate levels. Now, again, as we think about all this, we do have cutoffs. And in this case, it's typically cut off at 45 milligrams per day. And oxalate is found in many different foods. It's found in some cereals, rhubarb, Swiss chard, spinach is quite high in oxalate levels, peanuts, tea. So, very high consumptions, for instance, of iced tea, especially in the summertime, may get you more oxalate in your diet, and that may actually, paradoxically, cause you to form more kidney stones. So we need to think about all these different things. So detailed dietary history will really help your medical team think about you and try to help you be the most successful you can be. High uric acid levels in the urine. As I mentioned before in one of my earlier slides, uric acid stones tend to be a little bit higher in patients with ADPKD than in the general population. And so high uric acid levels in the urine, you want to try and think about being able to reduce these levels if possible. Again, the dietary history will be important. And you may have your medical team talk to you about, your consumption of purines. So purines are very interesting because these are basically these levels are highest in red meat, fish, and shellfish. So if you know of anybody that has gout, doesn't mean that you have gout if you have uric acid stones, but patients with gout tend to also try to avoid these things because it can cause elevations of uric acid. But back to kidney stone formation, trying to decrease the intake of meat to about 6 to 8 ounces a day may be really beneficial in order to cut down on your purines and hopefully decrease that uric acid level in your urine. You may also have that low urinary pH and being, again, treated, as you saw in an earlier slide, dealing with a citrate and elevating your citrate level on up may help to deal with that pH and help to bring it up a bit and decrease the potential for forming a uric acid stone. Now, when we look at all these things, and this is an extremely busy slide, as we look at, urinary and serum parameters in patients with ADPKD, it's very interesting here. So we know that there's certain things, this column here with the p-value, and NS means not significant. And so we can see in here that patients with ADPKD who have stones tend to have a lower GFR, which means they will have worse kidney function to some extent. But we can see here too, there's other things that we just didn't have enough data, for instance, in this particular study to really look at, well, what are some of the other things that really matter? We can see here citrate tends to be lower, but it wasn't necessarily significant. However, I would probably challenge that if we were to go through and repeat this study, if we were able to really look at each and every one of these things and optimize the calcium aspects of the urine, optimize the oxalate levels in the urine, optimize all these other things, and the uric acid down here, that we could put the person in a more favorable position for success. But we can see here, at least in this study, we have the GFR as being one of the significant differences between patients with stones and patients without stones. We can also see here other things with regards to even just the fluid too. We see that patients with stones tend to actually produce less urine than similar patients without stones. Now, in the earlier slides where I showed you that CT scan patient that had a stone and required an invasive procedure to go ahead and deal with it, in general, kidney stones are treated in very similar ways. You again want to go ahead, get a kidney stone. If you pass one, preserve it, put it in a little Ziploc bag, bring it in so that it can be analyzed by the labs. We can understand what your tendency is of a specific type of stone. If you don't have a stone or don't pass a stone, however, it's been seen on imaging, then really it's using a urine biochemical composition profile with typically a 24-hour urine collection to give your medical team, whether it's your urologist or nephrologist, a better understanding of exactly what are some of your risk factors that may cause you to form stones. So again, seek the guidance of your friendly neighborhood nephrologist who, again, in conjunction with urology as a team, can help to develop a plan to deal not only with your existing kidney stones, but also to try and prevent those future stones from forming. Key takeaway points I'd like you all to think about as we look at this. Well, especially now in the summer, as I mentioned earlier, don't underestimate sweat. Avoid saunas, avoid the excessive heat that may result in decreased urine output. We've all have been working out in the yard, sweating, doing things, and we've noticed that maybe we're not making as much urine. We're doing that. Our body is trying to conserve, your urine output, conserve volume and fluid in our bodies. And, you want to make sure that you're well hydrating yourself. Remember, your aim is between 2 and 2.5 liters of urine production a day. So that's 0.7 gallons of urine a day. Make sure you measure out a pitcher of water, water bottles, whatever is easiest for you to try and make sure that you're really looking at that hydration and taking in that fluid to help you on out. Remember, fruits and vegetables, you want to make sure that you're eating plenty of those that will give you additional fluid in your diet. Now, remember, as I mentioned earlier, calcium is not necessarily the enemy. Do not restrict your calcium unless your doctor or medical team tells you to do so. Because, paradoxically, reducing that calcium intake, especially if it's severely reduced, you may actually increase your risk for oxalate stones. So you need a certain amount of calcium for good, healthy functioning in the body, bone formation, etc. But if you go ahead and take too much in your system, well, that's not going to be necessarily good. That may cause some of that increased calcium excretion But if you have too little, it may paradoxically increase your risk for other kinds of stones to be formed. Again, that 24-hour urine collection will really help to understand more about what's happening in the body so that you can kind of figure things out more. Now, stones can recur despite treatment. And so that means, yeah, you may have a risk to form a future stone, even when you've dealt with everything that is visibly seen on imaging with your medical team at that point in time. But the goal certainly is to reduce that frequency. And so hopefully with a good treatment regimen, you can reduce that risk of future stones moving forward. And that's whether you have ADPKD or not. Save the stone if you pass one. Again, being able to go ahead and think about all the different types of stones that a person can make. If you have that stone in hand, if you can collect it with a strainer, you can then take that on in, it can be analyzed in the lab, and it can really help your team to figure out, well, what is it specifically that you make, and really help to target things a little bit better for you. Now, that may also include that you will go ahead and provide a very detailed dietary history. Whether it is if you are having excess calcium excretion in urine, thinking about, well, how much dairy are you taking on in? Are you taking excess calcium supplementation? These are important things to help your team understand you and make, quite frankly, a very detailed but specific plan for you so that you can be successful. So once again, that dietary history extremely important. But again, the other thing that to really think about is sodium. Now it's interesting too, because sodium, I didn't really mention that as much earlier. But in general, sodium you want to aim for about 2,300 milligrams per day if you form stones. You may need to reduce your sodium intake for other reasons, but in patients that form stones, having a lower sodium may actually be beneficial. Well, let me explain why. Because it sort of doesn't make sense in first glance why a reduced sodium level would help to go ahead and reduce your risk for stones. But what happens is when the kidneys try to excrete sodium, they'll also excrete calcium with it in the urine. And so if you have a very high sodium intake, and as your body tries to get rid of that sodium in the urine, you may then go ahead and excrete more calcium in the urine. And so the more sodium you eat, the more calcium you can excrete in your urine. And remember that having a lower sodium intake may also help you if you happen to have high blood pressure. So again, I want to thank you all for your time today, for joining me as we talk about kidney stones and ADPKD, why those risk factors tend to be greater, and again, why these things are extremely important to try and work with your medical team to form a comprehensive plan to help and reduce your stone formation. I hope you have a wonderful rest of the day and enjoy all the lectures. Thank you.